Okay, so good evening. I'm Sophie. I'm one of the anaesthetic trainees in the region. So far you've done A to D, and today we're going to talk about E, which, as you know, stands for exposure. Also, we're going to cover escalation, and we're going to cover everything else. And everything else, essentially, we're going to talk about renal replacement therapy. So it does seem a really broad category, and that's because it is, and it's quite context specific and patient specific. So in order to break it down, the objectives are, we're going to talk about the key elements of exposure as part of the clinical assessment. We're going to talk about the indications for renal replacement therapy. We're going to talk about the principles of renal replacement therapy, particularly with regards to critical care. We're also going to talk about the understanding of the levels of care in critical care. So those levels are level 1 to 3. And you will have talked about this already in the previous lectures, but we're going to discuss the key factors influencing decisions to admit a patient to critical care. So how we're going to do this, we're going to go through an example case. We're going to talk about the E in the A to E assessment. We'll talk about renal replacement therapy, admission to critical care, and as you've done in previous sessions, we're going to split into groups and run through some cases. So here is the case. So if you don't want to, I'll ask a couple of questions. If you don't want to answer, then that's fine. But if you don't mind writing in the chat, that's sometimes quite a useful way to see everyone's thoughts, and I can just talk about them. So in this case, it's a 46-year-old female with a background of a traumatic brain injury from a fall downstairs, and she's got a long-standing right-sided weakness. She's wheelchair bound, however, has got a good quality of life, can transfer independently, and she's independent with her ADLs. She presents following a fall from a wheelchair and is on the floor for 18 hours. She's been referred to critical care by the A&E doctor. And you take the call, and that is all the information you have. What are your initial thoughts? If you can just type in the little message box. Or if you want to speak, then that's absolutely fine. Yeah, so someone said check CK and renal function. Exactly. Yeah, exactly. Can she tell us more about the fall, any injuries? Exactly. So we've not really given very much information at all here, have we? So you would want ideally an RSVP handover, wouldn't you, from the A&E doctor? So it would be useful to think about what's a baseline like, what's the past medical history, what examination findings have you got, any observations, what investigations have you done, and what management have you initiated so far? So they tell you a little bit more, and then you go down to resource to see the patient yourself. And this is your examination. So this is your A to E examination. So airways patent, and she's GCS 15. B, her rest for 24. She's saturating 94% on a Venturi, and a chest X-ray shows a right basal consolidation. With regards to C, she's a little bit tachycardic with a heart rate of 112. Her blood pressure is 110/73, and she's peripherally shut down, and she's had a 500 ml bolus, and she's not passed urine in over 12 hours. You get a gas, and that's the gas result there. So she's got a pH of 7.23, a PCO2 of 4, a bicarb, that should say bicarb, is 14, base excess of -8, and a lactate of 2.7. So just looking at that gas, if you want to type in the box, what does that gas show? Yeah, exactly. Everyone's basically saying metabolic acidosis. So yeah, that gas shows a metabolic acidosis, and it's partially compensated. The CO2 is sort of low normal. So you've got a partially compensated metabolic acidosis. You've got a low bicarb, you've got an elevated lactate, and at this moment in time, you've got a safe potassium. Potassium is 5.1. You then examine E, and you see that she's got some skin breakdown and some swelling of redness on the posterior and lateral aspect of the buttocks, and she's hypothermic. You do some bloods, as you suggested, and it shows that she's got a CK of an elevated CK and a raised creatinine of around 400 and a raised urea of 36. Her white cells and CRP are also elevated. So at this moment, we'll just run through what we think is concerning. So A, not particularly concerned about A, airways patent and a GCS is all right. With regards to B, she's obviously got a right basal pneumonia, but she's holding her own from a respiratory point of view at the moment, so that doesn't seem too concerning. She's shut down peripherally, she's cool, she's tachycardic, and the thing that really worries me here is that she's anuric. Moving on to E, she's hypothermic, has got some skin breakdown and possibly another source of infection there. So essentially what you've got is a lady with a basal pneumonia, an anuric AKI, pressure sore, and she's hypothermic and septic. So what would you initially do? So this doctor's called you, they've had a 500 ml bolus. What would you initially do for this patient? Well, it's simple management really, isn't it? So you'd probably give more fluid. You would treat for infection with broad spectrum antibiotics. You'd manage for sepsis, somebody said exactly. Give more fluid. You would want to catheterize and monitor the urine output. Anyone got any other suggestions? So I think that's basically everything. Sepsis management, blood cultures, investigate any other source of infection and look for any other injuries. And she doesn't have any other injuries. Someone said warm her up. Exactly. You would want to warm her up. You could put a bear hugger on her or some warm blankets. And then what you want to do is you've done all of these interventions and then you would want to assess her response to those interventions. So you'd review her and you want to check that she'd improved both clinically and also biochemically. So you'd want to ensure that her urine output was picking up, or that she was a bit warmer and that she was more perfused. And you'd want to see an improvement in that gas. At this moment in time, when you're asked to call up your ITU consultant after going and reviewing this patient, do you think that this patient needs admission to critical care at the moment? So I would say not at the moment. We've got a few more things that we can do, as you've just mentioned, that we've talked about. So what we'd do is see how she gets on with those management. Someone said if it's single organ failure and is being managed, no, exactly. So she's being managed at the moment, and we'll assess that response. So you decide that it's too early to admit to critical care. You give another 1.5 litres of fluid and you review again. We've already talked about what will influence our decision to admit to ITU, and we can talk a bit more about that later. And we can also talk about any interventions that we'd not offer a little bit later on in the presentation. So you would ideally want to give your consultant RSVP handover. So I'll just give you a bit of an example of that. So reason for calling up is you would say, I'm Sophie, I'm one of the junior doctors. I'm just calling about a patient that has been referred to you. It's a 46-year-old lady with pneumonia and an anuric AKI. She was referred to ITU for renal replacement therapy. However, I don't think that's necessary at the moment. Background and story, she's wheelchair bound. She's had a previous traumatic brain injury and a right-sided weakness, but is independent with her ADLs and has otherwise a good baseline. She's got elevated CK and urea and creatinine. She's only had a 500 ml bolus, and I think we could initiate more management before referral to intensive care. So that's the type of handover that you'd like to receive and the type of handover that you should give. So your ITU consultant agrees. Initially, the patient's catheterized. They only pass 10 mils of urine over the next couple of hours. They're admitted to critical care for ongoing monitoring, and they have a dialysis catheter inserted. She has a renal replacement therapy because her acid-base balance doesn't improve, and in fact it deteriorates, and she remains anuric. So you've done a good job, and she makes a good recovery and is discharged back to the ward after 3 days. So this is an example of a patient that doesn't initially need admission to ITU, but it's somebody that you would probably want outreach to review or yourself to go and review because they may well need admission later. And that's exactly what happened in this case. So if we talk about exposure, So as I mentioned at the start, exposure is quite a focused assessment, and it's context dependent and very patient specific, and also place specific. So if you were in resource, as we were in this case, you would do full exposure, look for any evidence of any rashes, look for any wounds, any injuries, etc. You want to do an abdominal exam. You'd also look for track marks, for example, if it was an intravenous drug user. If you're in a slightly different situation, this was a trauma call, you'd want to do a primary and a secondary survey. So your primary survey, I don't know if those of you who've done ATLS, includes the A to E assessment, is part of the A to E assessment. And then the secondary survey is a much more detailed survey where you look for other non-life-threatening injuries once the patient has been stabilised. Then in terms of everything, if you were doing an intensive care daily review, E stands for basically everything else. And that includes nutrition, lines, when they were put in, if there's any evidence of any infection, fluid balance, so fluid in, fluid out, the amount possibly dialyzed off, etc. Also, NG feed, aspirates, and glucose. So that's the case. And now we're going to talk a little bit about renal replacement therapy. So this when I first started learning about renal replacement therapy, I found it a little bit confusing. So we're just going to keep it simple and break it down. So we're going to talk about indications and timing, the access required, the duration of renal replacement therapy, the modes, and there's a couple of main modes. We'll talk about anticoagulation, and then we'll have a look at a dialysis circuit and just bring all of that together. So, indications for renal replacement therapy. There's a very useful and simple mnemonic called AEIOU. So A stands for acidosis, E stands for electrolytes. And when we're talking about electrolytes, really we're talking about potassium. I stands for ingestion, and by that I mean toxins. O stands for overload, and U for uremia. So you may well be acidotic or have a high potassium, but dialysis is only indicated really if that is exceptionally high and is causing failure or damage to an organ system, or it is resistant to treatment. So with acidosis, severe acidosis, so a pH of less than 7.1, but you can often get patients in DKA who present with a pH of less than 7.1, and you don't initially dialyze them. So again, it is dependent on the underlying cause of the acidosis. Then a potassium of greater than 6.5, which is resistant to medical management, and particularly in those patients who are anuric because they've got no real way of getting rid of that potassium. Patients who've ingested toxins which are water soluble, so there's certain ones which you can dialyze out, and you can see that on ToxBase, for example, if you're unsure, but there are certain ones which are known to not be able to be dialyzed, which you're unable to dialyze, and that is aspirin and lithium, for example. Overload, so this is particularly important again if a patient is anuric, because again, even if using diuretics, etc., you're not going to be able to get the fluid out of that patient unless you pull it off with a dialysis machine. And then uremia. So uremia, which is high and causing organ damage, so cardiotoxicity or uremic encephalopathy. So if we talk a bit more about acidosis, so acidosis is really bad. It causes cardiovascular, respiratory, and neurological issues and electrolyte disturbances. From a cardiovascular point of view, in summary, it reduces the heart's ability to contract well, and reduces the ability, reduces perfusion to the rest of the organs. So reduced myocardial contractility, you get peripheral artery vasodilation and peripheral venous constriction, and you also get pulmonary artery constriction as well. From a respiratory point of view, acidosis can cause something called the Bohr effect. So the Bohr effect essentially is where there's acidosis or a high CO2 that causes the oxygen hemoglobin dissociation curve to shift to the right, which means that oxygen is released from the tissues, released from the hemoglobin into the tissues to be used by acidotic tissues. This also means that it reduces the affinity of the hemoglobin for oxygen, so reduces the oxygen carrying capacity of the blood. Respiratory compensation can occur, and you may see something called Kussmaul's breathing, which I'm sure we all learned about in medical school, commonly associated with diabetic ketoacidosis. And from a neurological point of view, it causes arterial vasodilation within the brain, which causes increased intracranial pressure. So respiratory compensation does happen quicker than metabolic compensation. However, it still takes 12 to 24 hours to reach maximal compensation. There is something called the Boston approach, which is a rule for assessing compensation. It's not something that I've ever done personally in clinical practice, and I've never actually seen anybody do it. Essentially what it's saying is it gives you an idea of the amount of compensation you would expect. If CO2 is more than expected, you need to think, is the patient tiring and not being able to breathe off their CO2? Is there an element of chronic lung disease present as well? And is this in fact a mixed metabolic and respiratory acidosis? So I've got another question here, and it's sometimes a bit of a controversial topic, but it's, do you use sodium bicarb in an acidotic patient? Has anyone got any thoughts on that? If not, we can just run through it. Fine. Yes. So somebody said, yes, if it's metabolic acidosis and it's a normal anion gap. So yes, exactly. So when you add bicarb, I'll just show you the equation. If you look at the equation at the bottom of this screen here, when you add bicarb to acid, it produces carbonic acid, which then breaks down into CO2 and water. So by adding bicarb, ultimately, you are adding more CO2 and causing more acidosis. So of course, you wouldn't use this in a patient with a respiratory acidosis. You might consider it in a patient with a metabolic acidosis, providing that you can ventilate the CO2 off. And you can sometimes use it as a temporizing measure to buy time, again, providing you can ventilate the CO2 off. It is used in certain circumstances. So for example, if you've got a metabolic acidosis and a normal anion gap, and there are certain medications which you, in overdoses and toxic doses, that you would give sodium bicarb. For example, tricyclic antidepressant poisoning and also salicylate poisoning. Issues with giving bicarb is that it can cause hyponatremia, can cause alkalosis if you give too much and you don't monitor it, and it can cause worsening intracellular acidosis. So in circumstances, yes, it's something that you would discuss the consultant with, but generally, if somebody is not improving with initial management of their metabolic acidosis, then consideration of renal replacement therapy and treating the underlying cause is the mainstay of treatment. So hyperkalemia, I'm sure you spend a lot of time treating this, so I don't really need to run through it. But essentially, if somebody's hyperkalemic, your initial management is to discontinue any nephrotoxics, discontinue anything which has high amounts of potassium in. You can give them fluid and rehydrate them. You can use Hartmann's. It mentions here 1.26% bicarb. That's something that is often would be administered in ITU if at all. And then you use other measures. So if there's any evidence of cardiotoxicity, or if the potassium is particularly high, you'd use IV calcium gluconate or calcium chloride. You can use salbutamol and insulin dex. So if you end up in the situation where a patient is anuric, euvolemic, and still hyperkalemic, you're in a bit of a sticky situation. You're very much likely needed to use renal replacement therapy. So renal replacement therapy can be initiated early or late. There are a couple of trials here, and essentially they both say that there's no real difference in the outcomes between early and late initiation of renal replacement therapy. The benefits of initiating it early are that you can correct abnormal physiology sort of sooner, with less, with the idea that you have a reduced amount of time in, for example, with hyperkalemia or in an acidotic state. With regard to arguments for late initiation of renal replacement therapy, it means that you truly are initiating it on patients that do need it, rather than doing it too early on patients who may have corrected their own physiology. And renal replacement therapy is not without complications. You get large fluid shifts and hemodynamic compromise. There's complications with vascular access, and it does take a big toll on the body having renal replacement therapy. So access. There's different ways that you can receive dialysis. So you can have peritoneal, arteriovenous access, and veno-venous access. So the first two, peritoneal and arteriovenous, are for patients who have more long-term chronic renal failure and need longer-term dialysis. So peritoneal dialysis, these patients have a peritoneal catheter. It looks a little bit similar to a suprapubic catheter, except it's in a slightly different place. It's connected to a small dialysis unit, which is portable, so the patient can have dialysis at home. And they're essentially the benefits of it. The risks, of course, are that you've got a catheter into the abdomen and there's an increased risk of peritonitis. You don't really see these too often, and you're more likely to see them on a renal ward, but occasionally they will occur on ITU. Then there's patients with arteriovenous access, and by that it essentially means fistulas. So a fistula is a formation between the artery and a vein. It's usually performed by the vascular surgeons. Takes about 40 minutes to do, and performed under a block in theatre or local anaesthetic. Once it's been formed, it needs a period of time to mature, and that's usually a period of months. And by mature, it means that the vein becomes stronger, gets a stronger wall, and you're able to use it as a fistula. And it's something that the renal nurses use all the time. Benefits are that it's within the body, so you've got a reduced risk of infection, although of course they can still get infected. There's a risk of clots, and there's also a risk of Still syndrome, which is where the circulation bypasses the hand and you get a pale ischemic hand. And in those instances, the fistula may need reversing. So what we do in critical care mostly is veno-venous access, and essentially that means lines. So you can have an internal jugular, which is ideal, followed by a femoral, followed by a subclavian. Femoral is less ideal than an internal jugular, just because there's concerns of increased risk of infection. So I'm sure you've all seen femoral central lines. So in intensive care, you insert a dialysis line, which we commonly call a vas cath, which has 2 or 3 lumens. The first lumen takes blood from the patient to the dialysis machine, and the second lumen receives blood from the dialysis machine and returns it to the patient. You can have something called a trialysis line as well, which is another smaller lumen where you can attach vasoactive drugs, which sometimes are required. So this is where I used to find it a little bit confusing, because there's a lot of names which sound very similar. So we've already mentioned peritoneal dialysis. We'll park that to the side because that's something different, okay? We won't talk about that. But there are several different modes, and the first one being intermittent hemodialysis. Then there's continuous renal replacement therapy, and there's a hybrid of both of those. So intermittent hemodialysis is faster. It's a single session of a few hours, and these patients need to be relatively well because you get quite large fluid shifts. So this is sometimes can be done on an outpatient basis when patient comes into the renal unit. Continuous renal replacement therapy lasts for a much longer period of time, 48 to 72 hours. You get smaller fluid shifts because it's done over a longer period of time, which means it can be used in patients who are more unwell. So it's more hemodynamically stable for those septic patients or those with acute renal failure. Examples of this are CVVH, CVVHD, and CVVHDF. So this is what used to confuse me. So CVVH stands for central veno-venous hemofiltration. CVVHD stands for central veno-venous hemodialysis, and CVVHD is a combination of both of those, which is hemodiafiltration. Then the hybrid that we talked, which is a hybrid of continuous renal replacement therapy and intermittent hemodialysis, is something called SLED. And some units also do use that. So on intensive care, you're most likely to see CVVH, CVVHD, which are examples of continuous renal replacement therapy, and also SLED, which is a hybrid of continuous and intermittent. So if we have a look first at dialysis, and then we'll look at filtration. So on the left-hand side of the blue box, you can see the patient's blood moving in one direction. It's separated by a semi-permeable membrane, which is represented by those white lines. On the right-hand side, you've got a dialysate solution in the dialysis machine, and that is flowing in the opposite direction. So essentially it's a countercurrent flow. And as they're both flowing in the opposite direction, it maintains a concentration gradient. So you get solutes moving from the area of higher concentration to an area of lower concentration. And those solutes get pulled across the membrane via diffusion. Generally, water doesn't follow. So in pure dialysis, you don't remove water. And in the other diagram there, you can just see an example of blood bathed in the dialysate solution and a cross-section of what that looks like. So this is the solutes move down a concentration gradient. So filtration works differently to this. On the left-hand side here, you've got the patient's blood, which is under high pressure, and then you've got a lower pressure on the right side of the diagram. The patient's blood, the water within the patient's blood, therefore moves from a higher concentration to a lower concentration down a pressure gradient, from a higher pressure to a lower pressure down a pressure gradient, not from a higher concentration to a lower concentration, as it does with dialysis. Therefore, you get big fluid shifts in this, bigger fluid shifts, and the solutes are pulled across the membrane when the water moves across the membrane by convection. You can obviously remove a lot of fluid doing this method, and in order to prevent hypovolemia, at some point within the circuit, you need to add a balanced solution back to the blood to avoid hypovolemia in the patient. As you are taking the patient's blood and put it in through tubes and through a dialysis machine and then through more tubes and back to the patient, there's a high risk of the blood clotting. So you always need to think about anticoagulation. So there's the option not to anticoagulate if you're particularly worried about the patient bleeding. Often heparin is used. With heparin, its systemic side effects, increased bleeding risk. It can be difficult to monitor and keep within the therapeutic range. There's risks of heparin-induced thrombocytopenia as well. So another option is using regional citrate anticoagulation, where within the dialysis machine, citrate is added, which chelates calcium, which is used in the clotting cascade. Issues with this are that it can reduce calcium, and therefore at some point you may need to add calcium back in. Can also cause metabolic derangements. So the nurses will monitor this, do repeat gases, and you'll be informed when the calcium drops. So this is an example of a circuit. So this is a CVVHDF circuit, which is a combination of dialysis and filtration. So red represents the patient's blood leaving the patient and going to the machine, and blue represents the patient's blood leaving the machine and going back to the patient. So as you can see, it's probably coming from a neckline, may or may not be anticoagulated. It passes through a pump through the dialysis machine. So it's either dialyzed, in which case it passes through the dialysate, as well as being filtered, and the waste fluid is siphoned off. At some point, replacement fluid is added, and if indicated, calcium can also be added if citrate is used. So we've talked about exposure, and we've talked about everything else, and everything else really we've talked about renal replacement therapy. And now we're just going to talk a little bit about E for escalation. So you will have covered this quite a lot already over the course, but in general, there are two main reasons for referral to critical care. The first one is that the patient needs support of one or more organ systems. And the second is that patient needs higher level monitoring, whether that be an arterial line, very frequent bloods, cardiac monitoring, etc. And then just to mention the different levels of care. So level 1 is ward-based care, level 2 is HDU, and level 3 is ITU. So level 2 HDU means that the patient just needs one level of organ support, which does not include invasive ventilation. And level 3 is that the patient needs one or more systems supported, or invasive ventilation. And it also is useful because it gives an idea for the amount of nursing care that's needed. For example, one nurse can only look after one level 3 patient, whereas one nurse may be able to look after 2 level 2 patients. And that depends on the demands of the patient, agitation, etc., any infection control risks. So thinking about all of that, the final question really is, what does an intensivist want to know when deciding whether to admit a patient to critical care? So this is quite general, but in general, what does an intensivist want to know when you're talking to your intensive care consultant after you've received a referral? You can just write in your box. Yeah, exactly. The patient's functional baseline. A couple of you have said that. Is the situation reversible? Exactly, very important. If it's not reversible, then you need to be thinking about levels of care. Someone said, which organ systems are compromised? Exactly. What do you want intensive care to do? Exactly, essentially. Which organ systems can intensive care support? Exactly. So I think that's a lot of them, really. So what intervention is being sought? Patient's baseline. The rapidity of decline is also important. You know, if it's been a slow, gradual decline, perhaps this is moving towards the end of the patient's life. However, it's a rapid decline. It may well potentially be something that you can do something about and intervene. Whether it's reversible. Previous decisions on ceilings of care, so whether the DNA are in place, whether there's an emergency healthcare plan. And the thing that we always forget to mention, even though it's really obvious, is the patient's and the family's wishes, okay? And some patients do have really strong wishes on whether they would or would not like to go to intensive care. So next, we're going to break into some rooms and do some group discussions. So you just need to remember that you're the critical care resident taking referrals. You need to think about what else you'd like to know. What are the management options? So should this patient be admitted to critical care? Should this patient be for full escalation? And should this patient have treatment limitations? So in conclusion, don't neglect E. In the A to E assessment, it can show you many things and you may miss things and miss clues as to the diagnosis if you don't thoroughly examine the patient. When thinking about renal replacement therapy, don't overcomplicate it and just stick to basic principles. Different units will do different things, but as long as you understand the basic principles, you'll get it. Admission to critical care is difficult. You have to consider several factors and you need to consider whether the patient requires organ support, higher level monitoring, and whether that can be achieved on the ward or not. And do they have the reserve to making meaningful recovery? And is this pathology reversible?